Heard you, Pam. Good morning, everybody. My name is Matt Seeley. I'm the chair of the LTSS Subcommittee meeting and this is the April meeting of that subcommittee. So if you're here for that, you're in the right place. Pam, do you want to start?
I'm going to try to check. I think there's a problem with my to you. I think I'm only
Can you hear me? Okay. It's easy to tell if this microphone's on. All right, this is Matt again. I'm going to go through the housekeeping rules. The meeting is being recorded. Your participation in this meeting is your consent to being recorded. The meeting is being conducted in person and as a webinar. To comply with logistical agreements, we will end promptly at 1 p.m. To avoid background noise, please keep your devices muted and the microphones off unless you are speaking. If you are attending the meeting in person, hi there, please keep background noise to an absolute minimum. The room is fitted with ceiling microphones that pick up everything. One of the chairs will report in-person attendance. Remote captioning is available at every meeting. The CART captioning link is on the agenda and then in the chat. It is important for only one person to speak at a time. Please state your name before commenting and speak slowly and clearly so the captionist may capture conversations and identify speakers. Questions and comments. Please keep your questions and comments concise and to allow time for everyone to be heard. Webinar attendees may submit questions and comments into the question box into the GoToWebinar or use the raise hand feature to be put in the queue to speak live. Those attending in person should use one of the microphones and wait to be called upon to speak. The tabletop microphones are reserved for committee members. Microphones are limited, so you may need to wait for OLTL staff to bring one to you. The general public should use the microphone sitting on the table at the rear of the committee tables. OLTL staff are available for assistance. Microphones. Before speaking into a microphone, use the power switch. Use the power switch on the top middle of the microphone body to turn the microphone on. The switch should be pushed towards the end of the microphone you speak into. When you are finished speaking, push the same button towards the bottom of the microphone body to turn the microphone off. Public comments. Time is allotted on the meeting agenda for 2 public comment periods. If you have questions or comments that were not heard, please send them to the resource account email found at the bottom of the meeting agenda and on the LTSS Submac webpage. The emergency evacuation procedure. In the event of an emergency or evacuation, everyone must leave the building and assemble in the first responders plaza. OLTL staff will be available in the safe area in the front of the elevators to provide any assistance. Please see the back of the agenda for more information.
Hey, Matt, I think I fixed it. This is Pam. I had joined twice, so if you want me to do the attendance when it's time, I can do that.
Sure. Okay.
Is that where we are? Should I go ahead and do it?
Yes, that's where we are. Thanks.
Okay, great. All right, so attendance. I know that Matt Seeley is present, and I am. Abigail Foster. Allie Conley.
Good morning, I'm here.
Andrea Costello.
I'm here.
Anna Warheit.
Good morning, this is Anna.
Carol Marfisi. Neil Brady. George Fernandez. Ginny Rogers.
Good morning, Jenny's here.
Hi, Ginny. Jay Harner.
Present.
Hi. Kathy Cubitt.
Good morning, I'm here.
Good morning. Laura Lyons. Linda Litton. Lloyd Wirtz. Lynn Widener.
Good morning, I'm here.
Michael Galvan.
Morning here.
Michelle Garrett. Monica Vaccaro. Natalia Gomez.
Good morning, everyone. Natalia's here.
Good morning. Rebecca McTaggart. All right. Has anyone else either joined or was unable to mute who wants to tell me that you're here? Okay. And just in case this wasn't said before, this meeting is being recorded. Your participation in this meeting is your consent to being recorded. All right. I think that's the attendance for now.
Over to you, Juliet.
Thank you, everyone. Good morning and welcome back to the hybrid LTSS Services and Support Subcommittee meeting. It's great to see so many faces in the room here with me. I'm going to start off on the agenda with just a few updates from me. We're going to do some public comments. Last meeting on the agenda, we had separated out the HR1 updates as an agenda topic. We do intend to keep that moving forward. However, there was no meeting between then and now, so I'm just going to do some general updates on HR1. And then we're going to go into a presentation from my team, have a break, and do a discussion panel with the subcommittee members and our MCO partners on the CAP survey, and then have our last public comments. So the agenda for my updates today, we're going to do my usual procurement slide, talk a little bit about the inter-RAI, go over some general happenings, and OLTL communications. So many folks should be very familiar with this slide. If we move forward a couple slides. This slide, folks should be very aware of this slide. There are no new updates on the CHC RFA. It continues to be in a stay. Services continue along the agreements that are currently in place with the 3 CHC managed care organizations. We go to the next slide. You may have recall that we talked about this quite some months ago about OLTL beginning the process of transitioning from the inter-RAI version 9 to version 10. That is predominantly mostly kind of an information systems update, but there are some questions that have been changed. There's no impact on the functional eligibility determination. As you know from the prior meeting, we had 2 individuals from the LTSS Subcommittee meeting that has worked with the OLTL team, looking over what those changes would be for the inter-RAI. For folks who are not familiar with the inter-RAI, it's one of the assessment tools that we use. We use the home care version. And it's been in Pennsylvania since April 2018, the inception of the transition over to the MLTSS systems transformation. So, like I said, it's mostly a software upgrade and not an assessment tool logic modification. We're not making any material changes to the functional eligibility determination that will cause changes in outcomes from version to version. So the software development process has been completed. We are currently in the testing phase to include the software testing and data sharing testing amongst the different entities that need to be involved in the systems connection. Training development is underway with the Deering Consulting Group, who is the vendor that has worked with us for many years on online training modules. Those are anticipated to be available in late June to all the assessors to be able to ensure that they can complete the training prior to going live. And as I mentioned before, Kathy Cubitt and Pam Waltz are participating in the training review as the representatives from the LTSS Subcommittee. Go Live was planned and is still planned for the beginning of July 2026. I commend the team, our MCO partners, and our vendors for all of your work in this area to make sure we are still on time and on schedule to have that come online. All right. So let's talk about some general happenings for the Office of Long-Term Living and our systems. An update from our policy team. We have submitted both the Omnibus Budget Reconciliation Act, or OBRA waiver renewal, and the Community Health Choices waiver amendment to the Centers for Medicare and Medicaid Services. The OBRA renewal was submitted to CMS at the end of March 2026, and the CHC waiver amendment was submitted to CMS at the beginning of April 2026. CMS has 90 days to approve, deny, or request additional information. And so we have that clock ticking. During the public comment period, we received comments from 8 different commenters for the OBRA waiver. We thank those commenters. And from 12 different commenters for the CHC waiver amendment. And again, our gratitude for your comments. Once the renewal and amendment are approved, we will present the finalized changes at a future Long-Term Services and Supports Committee meeting. Okay, additional general happenings. So the Office of Long-Term Living, we have released the 2026 CHC agreement pending approval from CMS. So it is a draft. It is not the final form because it's still going through the Commonwealth review process and pending approval from the Centers for Medicare and Medicaid Services. So we are looking forward to CMS's approval, denial, or additional questions. We usually get a couple rounds of questions before it's finalized, so that's kind of the process that we're in right now. This is a change, and it's done at the request of our stakeholders who have asked us to publish it pending final form, with the understanding that everyone understands it is still technically in sort of draft and changes could occur. We also wanted to highlight from our Bureau of Human Services and Licensing team that there are free annual trainings for personal care home and assisted living residence administrators. So we have them listed here on this slide. So there's some that have occurred and some that are still to come. It seems here that the ones that have occurred are here and not the ones to come. So we will correct that on the slide to make sure that the free trainings that are still available for March, April, and May are listed. And we encourage the personal care home and assisted living resident administrators to take a look at that. It has gone out on the BHSL listserv. So we do encourage you to take use of those free resources. Moving into some recent communications, the first one's related to HR1. So on March 19th, via the listserv, we did release the slides that was shared and presented at the first DHS resolution implementation committee meeting, which occurred on March 5th. As folks may know, our LTSS subcommittee members that are representing this group on the HR1 implementation committee are Pam Waltz and Rebecca McTaggart. HR1 implementation updates and discussions will be a standing agenda item during future LTSS subcommittee meetings where Pam and Rebecca will be providing updates for this group. In addition to taking recommendations, suggestions, and questions from the subcommittee members back to the HR1 Implementation Committee, and certainly things that we hear during the public comment period. So the HR1 committee is going to be fully integrated in all of the MAC meetings and MAC subcommittee meetings, using this committee structure as it's intended to kind of provide advice and feedback on the process. This is the structure for the advisory committees to the Medicaid program, and so these committees will sort of, and those representatives will kind of be that link back and forth. The Department of Human Services has designated a resource account, which is on this slide. I will read it out. RA-HSPADHS-HR1@pa.gov. So if you have questions or want to provide feedback related to the HR1 implementation, please feel free to use that resource account. It'll go directly to the DHS team that is helping to support the HR1 implementation committee. Certainly, you can always give feedback during our public comments on things that you'd like to have us hear and bring up through the LTSS committee. And for questions and suggestions that you want to sort of relay to Pam and Rebecca, you can certainly still use the RA account for the LTSS subcommittee. So additional information regarding HR1 implementation can be found on the Pennsylvania Human Services Helpers webpage. The link is here, but you can also easily navigate to it by going to our DHS website. All right. Additional communications that I wanted to highlight that I'm really excited about is our VBP showcase, the value-based payments showcase. So on March 17th, the Office of Long-Term Living, we released via our listserv. We announced the launch of the application period for the Value-Based Purchasing Innovations Showcase. This is being led by the National Managed Long-Term Services and Supports Health Plan Association. They also hosted, I think, a very informative webinar yesterday about the Value-Based Program Showcase. It's also in partnership with our CHC MCOs, and I am very grateful to them for working in partnership with us on this effort, because I think it's sort of the first time this has happened in the MLTSS space. So through a competitive application process, a subset of providers will be invited to present their ideas in person at a VBP Innovation Showcase in Harrisburg, scheduled for Wednesday, August 12th, 2026. There is a brief application form that is available online, and all responses must be submitted by Friday, April 17th. So 16 about a half a day to go to get those applications in. The webinar I mentioned happened yesterday, but if you do have additional questions, certainly please email them to the MLTSS Association at info@mltss.org. There were some great questions and feedback at the webinar yesterday. I know the teams are looking at those, and I believe I'm going to look at Montreal for affirmation. They are going to be putting out FAQ in response to those questions shortly. So they're being reviewed. Very excited about the participation, and really am looking forward to what is received. As just an update for folks here to kind of clarify the Office of Long-Term Living's role, our quality and assurance team will be taking a look at all of the applications for the purposes of giving some confidence that those applications will meet the medium or high risk value-based payment models. That is what we're looking for in this showcase. Medium to high risk. It must meet those standards. My team will look at those applications to kind of say, with some, given it's the first time we might be seeing them, some reasonable confidence, not a guarantee to the MCOs, that we would look favorably on these as meeting the medium to high risk criteria. And then that will allow the MLTSS Association and the CHC MCO and the selection committee, which OLTL is not a part of the selection committee, to evaluate those applications in a competitive process for the final invitations. And with that, I also have one last update. It came out yesterday, so hot off the presses and not on a slide, is that the annual review process for our fee-for-service programs have started. That went out on the listserv to service coordinators. Just want to have folks pay attention to that and get that process started so we can get all of those ISPs in and approved by the end of the budget year. Appreciate that. So we can go to the first public comment period, and I'll hand it back over to Matt.
Okay. Well, do we have any comments in the room? Wow, Mike.
Good morning. Hi, I'm Lisa Tesler. I'm the Executive Director of the Developmental Disabilities Council. And I guess this is more of a question than a comment, and it's about the HR1 committee. So, representing the intellectual, developmental disability, and autism community, I wanted to know how members of the ISAC will be part of the HR1 discussions. Will the leaders, I've heard MAC is the avenue for discussions and report out with progress from the HR1 committee. When and how will the ISAC members be looped into that conversation? Will the HR1 committee leadership be reporting to ISAC, coming to our meetings and asking for our input?
So really appreciate the question and the comment. I don't oversee the ISAC, so I don't necessarily have the answer for you right now. I can certainly follow up with Kristen Ahrens and Catherine Stetler about that. I'd also encourage you to raise that up in the resource account so that the whole group that's working on it has awareness. I don't have awareness into that resource account, but it's my understanding that all the MAC subcommittees should have representation. I'm not on the ISAC, so I can't really speak to that. Do you know who chairs that?
Okay, so which RA account would you like me to send this question to? The HR1 account? Okay. Yes, and I will certainly follow up as well, but if for a direct answer directly to you, I would recommend that as well. Okay. Yep. Thank you for raising it.
Any other questions in the room? Paula, are there any, or who am I asking? I don't know.
Hi, Matt. This is Paula.
Hi, Paul.
Hi. I do have some questions in the question box. First question is from Bill Herzog. He's asking who made the decision to wait until June to pay the back pay to DCWs.
So let me make sure that I heard you correctly. Paula, you said the question was who made the decision in June to raise the maximum rate for direct care workers?
Let me repeat. Who made the decision to wait until June to pay the back pay to direct care workers?
Okay, I think that is a specific question for the CHC managed care organizations. So I don't necessarily have the answer for specifically why June will be the date for the retroactive payments. It's most likely having to do with the manual claims reprocessing that needs to occur for that to occur, but I don't know specifically. If anyone from the CHC-MCOs would like to come up and address that, that would be great. If you don't have someone who can speak to that, we can certainly follow up and put it out after the meeting as we usually do. So I'll take a moment to look at my audience.
I need to, who can unmute someone?
We are currently working to unmute a CHC-MCO representative and pull them over so that they can answer that question for Bill.
Hi, this is Frank Santoro from AmeriHealthcare Talks. Can you hear me okay?
Yes, we can.
Hi, thank you for the question. The 3 MCOs worked with Tempest and decided that they were going to take all of the requests for increases in wages and then do a one-time retro adjustment back to January.
Thanks, Frank. I do want to point out that certainly, we wish we could have had all of this in place much sooner than we have, but certainly we were at the mercy of the budget impasse. I know that seems like a long time ago, but that did take away 6 months from our ability to plan and put this in process. So we do ask, again, for folks' grace and patience because it is a complex process for implementation. We certainly have gone as fast as we can across both systems. So thank you. Additional questions?
Hi, this is Pam Walls online. Can I ask a question?
As a committee member, always.
Okay, great. As we know, I think it's the Senate Energy and Commerce Committee, I think, sent a letter to Pennsylvania, among other states, inquiring about the possibility of fraud in waste and abuse. And a response was due to them by March 13th. Did the Commonwealth respond, and will that response be available for us to see?
Great question, Pam. Yes, the EMC did send a letter to various states inquiring about their program integrity processes. Pennsylvania was very proud to have the opportunity to share what we do in Pennsylvania related to fraud, waste, and abuse in our Bureau of Program Integrity operations and efforts and partnerships across the Commonwealth to make sure that we are combating fraud, waste, and abuse in our programs. Pennsylvania, as you may know, is one of the leading states with regards to convictions around fraud, waste, and abuse, and we're certainly very proud of that as well. It means that things are working. People are reporting what they see. Further emphasize, if folks see something, certainly say something. It's incumbent upon all of us in this program, every single person, to report any suspected fraud, waste, and abuse. That continues to ensure that our efforts are very vigorous. There was a response that was sent back to the ENC by Secretary Arkush in response to that letter. It isn't our intention to certainly publish what we can with the letter. However, at this point in time, usually when things go back and forth from us to the ENC, there are additional follow-up questions. So we are waiting for those follow-up questions to conclude so that we can kind of make any changes that we need to make, answer all the questions that we need to make, clarify things that may need to be clarified, and certainly will be intending to put that information out there.
Okay,
I don't have a date for you, Pam. But I know
Okay.
that's the intention, but great question. Thank you.
Okay, so what you're planning to release is whatever the things that you're going to, and the Commonwealth will end up doing as a response to the letter? Is that it?
Well, at this point in time, it was an informational letter. It wasn't a letter
Right.
directing us to do
Right.
or change anything. And as I said, we're really proud of all of our program integrity efforts, both at DHS and certainly the CHC MCOs and their responsibilities as well. So there isn't any planned changes really to discuss. It was a request for information.
Right. Okay, thank you.
Any other questions, Paula?
I do have a few questions. First, I do want to note that Bridget Lowry is on the line filling in for Monica Vaccaro, and Laura Lyons has also joined the call.
Cheryl is also in the room. And more.
A question from Rob Latin for the value-based or the VPB showcase. Do I understand correctly that providers chosen to present will do so in front other providers?
So Paula, just for note, you're coming in and out occasionally. I'm not necessarily picking everything up. Was the question about the PAS reductions from the prior LTSS subcommittee?
Not this one.
Okay, well, can you repeat it again?
Sure. For the VPB showcase, do I understand correctly that providers chosen to present will do so in front of other providers?
So, my understanding for the VBP showcase is that for providers who would like to not present in front of other providers because the information is kind of proprietary, sensitive, confidential, secret sauce, the recommendation that you will likely see coming out of the FAQ is to please note that in other information the committee needs to be aware of. So that's what my recommendation would be. I know that was a question that came up at the webinar, and the team is evaluating that, and I would look for a response on that FAQ that's coming out from the MLTSS Association. But thank you for raising it.
Hey, this is Paula. I have another question from Janelle Gleason. For the VBP showcase, the projects are asked to align with state-defined LTSS value. Can you point us to where the state defines those value measures? Would that be in the draft 26 CHC agreements?
Yes, great question, Janelle. And yes, I would point you to the draft 26 CHC agreement. And certainly if you have additional questions or need additional clarification, I'd encourage you to send the question to info@mltss.org. Any other questions, Paula?
I have a couple comments, but no additional questions. So comment is from Bill Herzog. The NRAI tool is not the problem. The problem lies when the MCOs take the NRAI assessment and put it into their own tool to determine level of service care. Next question is from Bill Herzog. Have the MCOs responded to the PAS reduction questions, concerns from the last meeting?
I believe we captured the questions that were brought up in the chat at the last meeting. We sent those questions to the CHC MCOs for their response, and I would direct your attention to the LTSS follow-up items that was sent out via the listserv, where you would find the answers that were submitted in response to the questions captured at the last meeting.
Are there any more comments? Go ahead.
One more, this is Paula, one more comment from Bill Herzog stating that do they know that the June date will cause problems?
We would need a little bit more detail about that, but certainly we appreciate the comment. I see one question come in, Paula, if I can address it quickly. It's from Anna Warheit from the committee. She's asking about whether or not the VBP showcase will be open to the public. It will not. This is, an activity and engagement through the MLTSS Association. It is not a public meeting. Thank you for your question.
If there are no more comments or questions, do we want, or can Brian and Steve be ready to comments early?
There's a couple of hands raised from committee members, if you want. Paula, do you want to address the raised hands?
Natalia, you've been unmuted. Go ahead and ask your question, please.
This is a comment. A lot of times dealing with our participants and myself as a participant, also an advocate, we hear a lot that the programs and the systems is very complex and sometimes painful experiences. And based on that, I believe that when these dramatic changes and complex changes, such as the one for self-directed participants with the increased rate and the back pay, my comment would be that I believe it should have been planned a little better to take into consideration the DCW sacrifices. They waited a long time for the increase that they're getting. And on top of that, they need to wait additional time to get the retro money. Just for future references, I believe that those are things that need to be taken more into account in how do we decipher, or how administration and MCOs decipher, Tempest decipher how these payments are going to be. And I agree with Bill, there's going to be some issues with that.
Natalia, I appreciate the comments, and certainly if I had a magic wand, we would not have had a 6-month delay and a budget impasse, and we would have had an additional 6 months to roll out that change. We did not, so we are doing 6 months of work in about 3 or 2. So certainly appreciate that. We do make every effort to try and make every transition as smooth as possible. We, also, had a lot of questions related to the implementation. We had some asks received from stakeholder groups and DCWs about how the implementation would go forward. And certainly, we do appreciate that there's always a difficulty with right and right now, and we were put in a position to do right now. Just for things outside of our control. It's always a great learning opportunity. We have learned a lot through this process. I think there's some really great innovations that have happened as well. Draw folks' attention to a form change that occurred across both those programs, where the common law employer can easily check a box that says, pay my worker the maximum rate we can, right? To really simplify that process so they don't even have to use a calculator. So there's been some great innovations along the way that were also able to have been implemented, but I certainly take your point very well, Natalia. Feel free to share that with, in this budget process as you guys educate and advocate about, the importance of having budgets be timely. Thank you. Are there any other questions or comments, Paula?
I have no other questions or comments. Thank you.
Okay then. Are Brian and Steve ready then? Thank you. Come on up.
Hi, good morning, everyone. Can everyone hear me okay? Okay, thank you. Okay, hi, good morning. My name is Brian McDade. I'm the director of our Quality Assurance division within the Bureau of Quality Assurance and Program Analytics. And one of the pleasures I have is overseeing with our administration and oversight of the HCBS CAP survey that we do every year to get the participant experience with the services that we provide. Not only for CAC programs, but also with the OPRA waiver as well. So with that, I will introduce Mr. Steve Kisner, who is our primary lead with the HCBS CAP survey. He's going to go over a aggregate review, prefer as our state aggregate, in regards to the results that we have. And then I believe after this morning's break, we do have some individuals from each of the CAC managed care plans who are graciously going to be attending here to do equivalent of a fireside chat to answer your questions and concerns regarding their programs. So, Mr. Kisner.
Thank you, Brian. We're doing things a little different this year. We're not going to be presenting the MCO percentages. We are just going to go at the state level and also at the CMS level, along with OPRA. So our first slide is with the community response rates. For the state response rate, it was at 5.5%. The survey completed 2,211 completed surveys. Broken down was 788 from AmeriHealth, 702 from PHW, and 721 from UPMC. With OPRA, there were 42 completed surveys. Their response rate was 8.1%. The Agency for Healthcare Research and Quality, which is AHRQ, they analyzed 36 surveys from 12 different states. Next slide, please. Moving on to the language. This year we had the limited English proficiency, the LEP services applied by Press Ganey to administer the 2025 survey. The data for the 2025 survey language, Oprah was at 97.62% for English, and for Spanish it was at 2.38%. For the community health choice, CHC, for English it was at 93.31%, and Spanish was at 4.34%. And then as you can see down, we took the 5 top languages, which included Arabic, Nepali, Russian, and I'm going to screw that one up, India. How's that? Which were all below 1%. Next slide, please. For the non-survey participation, we had the deaf language barrier is less than 1% due to the LEP provision that we put in 2025. With the CHC, it was below 1%. It was at 0.80%, and the Oprah was at 6.8%. For the answering machine for 2025 for Oprah was at 62.54%. No answer was at 5.93%. Busy was at 5.76%. Not qualified was 5.59%. And disconnected and working numbers for Oprah was at 5.42%. With the CHC, the answering machine was 60.96%. No answer was 9.84%. Busy was at 7.61%. The disconnected or non-working number was at 5.99%, and not available was at 3.98%. Next slide, please. For the respondent characteristics, African American for Oprah was at 30%, non-Hispanic was at 85%, female was at 32%, age 65 was at 2%, and the high school, grad, and some college was at 84% for 2025. For CHC, African American was at 38%, non-Hispanic was at 86%, female was 67%, age 65 is at 54%, and high school, grad, and some college was at 63%. With the race, the participants can select more than just one race, and as a result of that, the category may exceed 100% and should not be interpreted as mutual exclusively. Next slide. For Oprah, for the health, good and fair is at 43% for 2025. Mental health is at 61%. Lives alone is at 22%, and urban is at 86%. Compared from last year with Oprah, it was at 100%, so it has gone down 14%. CHC, for health, it's at 57%. Mental health is at 62%. Lives alone is at 54%, and urban is at 80%.
So do you want questions like now or later, or how do you want them?
Right after at the end of the session here, okay? Okay, going with the composite measures, the first one is staff listen and communicate well. The AHRQ, as you see, is at 2023 and 2024. That is the data from those particular years that we've handed into CMS. But whenever you take a look at their chart book, it is approximately 2 years ahead. So if you took a look at the 2023, it was at the 2025 chart book, and for 2024, is it at the 2026 chart book. So for Oprah, it increased by 2%. it's at 97%. For statewide CHC, it stayed the same, along with the AHRQ. Next slide, please. Personal safety and respect. With Oprah, it decreased by 2% to 96% from 2024. For CHC, it stayed the same. For AHRQ, it increased by 1% to 95%. Next slide. Service coordinator is helpful. For Oprah, they increased by 7% to 99%. For CHC, it's at 92%. They decreased by 1%. And then for AHRQ, they increased by 1% at 92% for 2025. Staff and reliable and helpful. For Oprah, they stayed the same at 85%. For CHC, they increased by 1% to 85%. And for AHRQ, they increased by 1% to 86% for 2024. Next composite measure, choosing the services that matter to you. For Oprah, they increased by 8% to 80% for 2025. CHC increased by 83%, by 1% for 83 at 83% for 2025. And for AHRQ, they stayed the same. Transportation to medical appointments. Oprah, they decreased by 2% for 2025. They are at 70%. CHC increased by 1%. They're at 80%. And AHRQ, they increased by 2% to 78% for 2025. For planning your time and activities, for Oprah, they increased by 1%. It's at 63%. CHC is at 60%. They increased by 3% from last year. And for AHRQ, they decreased by 1%. Just so you know that when we talk about the CHC, this is for all three MCOs. So this is the average for the three of them. I should have said that at the beginning. I'm sorry about that. For the overall participant experience, for Oprah, they increased by 2% for 2025. For CHC, they increased by 1%. And for AHRQ, they also increased by 1% to 81%. All things important to you. For Oprah, they increased by 10% to 63% in 2025. CHC increased by 2% to 70% in 2025. And for AHRQ, they stayed the same at 64% across the board. If you received care, rate your dental care, and we scored it from 9 to 10. So for Oprah, they decreased by 3% in 2025, and for CHC, they decreased by 2% for 2025. Ability to do things in the community. For Oprah, it increased by 10% to 50% in 2025. For CHC, it stayed at 25% across the board for 2024 and 2025. And AHRQ, they also stayed the same for 2023 and 2024 at 31%. Know how to report abuse, neglect, or exploitation. For Oprah, they decreased by 16% to 74% in 2025. For CHC, they stayed the same across the board at 86%. Aware of housing rights and how to get information for preventing eviction and foreclosure. With Oprah, they decreased by 6% to 63% in 2025. In CHC, they stayed the same at 75%. Know how to apply for SNAP benefits to help buy food. With Oprah, they decreased by 42% in 2025 from 100% in 2024. With the CHC, they decreased also to 87% by 3% from 2024, which was 90%. Get appointment for counseling or mental health treatment as soon as needed. For Oprah, they decreased by 21% in 2025 from 71 to 50%. With CHC, they increased by 2% from 61 to 63% in 2025. And then our sources, obviously, is the 2025 CHC and Oprah home community-based services. And also the chart books, as we talked about earlier. And for the calculating of the response rates, it's done by the American Association for Public Opinion Research.
Now questions. Okay, so thanks for reading to us what were able to read tonight.
So Lloyd, one of the things is the reason why the slides are red and the data is red is for universal accessibility purposes. We do understand that the majority of the population here in the room may be able to read it for themselves, but that is part of the best practice.
Well, that happened, and we had a best practice. Thank you. If we can go back to the slide that reports mental health, actually reports the physical health, but there was a section there that reported the mental health. It's way back. It's like maybe 7 or 8. Yeah, that one. How was the determination reached? What questions get answered and don't get answered for mental health good/fair for community health choices to drop from 66 to 62% is, of course, my interest.
Yes, I'll take this. Just in regards to this is based upon the responses received by individuals that participate in the survey, their response. And essentially, it's just a basic question as far as how the individual themselves would rate their mental health in that regards. So essentially, the scoring is really of a top box score nature, in which they indicated that they were doing fine, they're well, as far as meeting the parameters. As Steve had reported, that they were reporting that they were in either excellent health, very good health, or good. And then, of course, the other options were either fair or poor. So essentially, we're reporting back as far as individuals indicating themselves when they participate in the survey to the surveyor how they feel, what their mental health capacity is at the time. So it's strictly based upon the individual's response to just the basic question of, how would you rate your current mental health and well-being?
One question, nothing else.
Sure.
Okay, thanks.
You're welcome.
Thank you. This is valuable data and appreciate it. But as advocates, the texture of the data would be much more meaningful at the individual PhD MCO level. Would you have that data somewhere for us to look through?
Well, that is a great segue. This is Brian once again. We do have, as I stated at the beginning of the presentation, we do have representation from each of the plans who are definitely going to be going into that level of detail per the committee's questions and interests as part of that discussion. In the past, as Steve had pointed out, we have presented kind of like the side-by-side breaking out, not just the state aggregate, But this year, there was a little bit of a change of pace, per, I believe, some of the guidance from the committee leadership, in which to kind of give that opportunity for the plans to have, after this morning's break, to go into that level of details as far as how they're seeing the data applicable to their plans, as well as most importantly, from your perspective, what are they going to do with the data, per se, as improving the services.
Just as a quick follow-up.
Sure.
So several of the measures did not meet the 86% goal. What happens to that at this point?
Okay. Once again, I'm not trying to push this off to the next portion, but once again, the plans are definitely planning to address that as well, as far as what we refer to as areas of need or improvement plans, in which essentially we'll be discussing not just for this year, but also past year, as far as areas of need in regards to what initiatives they are taking as a plan to address those concerns for their participants to hopefully improve those numbers. One of the things I know we also see working with AHRQ, which is great, is we also have that national baseline where we can definitely see where other states are having similar issues or concerns being expressed or provided by the responses they get for their participants. So I know our plans have been doing an excellent job as far as addressing these concerns over the past several years. I think this is like year 7 or 8 we've actually had the survey in place. But they definitely also have a great relationship kind of working with each other and also with our team in regards to how they address those needs. So there's definitely a lot of effort being taken by the plans to address those identified concerns based upon the survey's results and, most importantly, the feedback that we were getting as far as the participants and their experience with the program.
Thank you.
Okay, based on that response, any questions related to the MCOs and what they're doing and going to respond? I guess we'll save till after the break. Are there any questions in the room?
From committee members?
Committee members?
Committee members.
We have 3 committee members who have their hands up on virtual. Yes.
Paula, do you want to address, or Pam, do you want to address those?
This is Paula. Kathy Cuba, you've been unmuted if you wanted to go ahead and ask your question.
Thank you. This is Kathy, and I would like to ask a question that would be helpful for this afternoon's discussion. Could you identify if you found any outliers for any of the survey questions for the individual MCOs, either on the positive or negative side? Since we're looking at numbers, composite numbers, it would be helpful to know if any particular MCO was doing well above, or if there were an MCO, again, doing under what we're looking at the slides. Thank you.
Yes, hi, good morning. This is Brian McDade again from OTL. Just in response to that, part of our review, we do review and work with our contract monitoring team in regards to these responses we receive, as well as OTL exec staff as a whole. And one of the things we do look at is when we do our analysis of plans to plans, we are pretty happy to say, well, of course, there's some measures that are below 86, so that's not always a good thing. But we are happy to say that when we do see for this year's survey, the decreases that we saw were pretty balanced in regards to each of the plans. So the plans themselves, hopefully when they have the opportunity to present, you'll see those numbers being discussed. Themselves are pretty much even or on par with one another. And probably even most importantly, a lot of them are on par with, like we said, with the results that we received from AHRQ in comparison for the national as well. So we didn't see anything that made like a giant red flag for any specific plan. We saw very similar as far as the fluctuations, increases or decreases across the board with the plans. And I think a lot of that is attributed to a lot of the open communication that our plans have with us as well as between each other as we go through the course of the year of reviewing this information and data and their provision of responses.
Thank you.
You're welcome. Are there any additional questions? Paula?
Hi, Matt. Natalia Gomez, you have been unmuted if you would like to ask your question.
I have two questions. One question is, how are the participants, how are we chosen to, or how is it determined to choose a participant to participate in the survey? And the other question is, what is in place to help you identify who are LEP's participants so that you can send the right surveys to them?
Okay. Those are wonderful questions. This is Brian again from OTL. And you actually beat me to the punch because I was going to end with this a little bit before we took our break. But we definitely encourage, just to answer your question quickly, we do basically each of the managed care plans and ourselves and working with our vendor in regards to administering the survey. There is essentially a random sample that is taken on sampling, and essentially we try to target the specific goal of targeted for each of the plans. We try to get 700 per plan, which exceeds the 95% threshold, which would be around 350, I believe, or somewhere. But nonetheless, we definitely target to make sure that we do have a valid sampling. And from that, the administrator of the survey, they do numerous outreaches to our participants to definitely make sure that they have the opportunity or awareness to by calling them. We also have outreach letters which go to actually all the participants for the plans in regards to letting them be aware that there's a potential survey coming. We do that about a month in advance of the survey's actual administration to bring awareness to the community as far as that the survey is going to be administered. And we definitely are very dependent on the individual participants themselves to actually answer the calls. That's one of the reasons why we looked at the disposition report regarding as far as drop calls, answer machines, and whatnot. That's also one of the reasons to flow into your other question regarding the LEP. That is not identified per se beforehand. We do like a blind sampling, so essentially the administrator of the survey doesn't say, oh, only certain languages or whatnot. That is really at the discretion of the participant once again. So when there is an outreach, we do hold the plans in our, in ourselves as far as the administration of the survey. If an individual is contacted and they happen to, their primary language need is not English per se, and they do require LEP services, that is put upon the survey administrator to arrange and provide the LEP to be able to administer the survey to those individuals using the LEP translation services and whatnot. With that said, the reason we really want to push that is because several years ago we noticed there was a lot of individuals, if you didn't speak English or Spanish, we didn't hear from you, and that's not fair. So we definitely want to make sure that we include the LEP provision. And we have definitely seen that significant drop, per se, as far as individuals saying they can't participate in the survey because of language barriers or even they are hearing impaired. So we definitely took that as far as a challenge, and it has been very successful. And I know the plans as well as our survey administrator have been quite pleased with the responses. There, the increased response rate actually tied into having that availability LEP for individuals. And I believe I answered both your questions. Please let me know if I did not.
Somewhat, but I guess we can have further discussion when it comes to the LEP population.
Okay, this is Brian again. So in regards to the LEP population, once again, essentially, we do provide the LEP services for the individuals to assure them they have full opportunity to participate in the survey. So once again, that is just very similar to how we do with the department as far as the availability and provision of LEP services for individuals. That's really just based upon the survey participants' request for this service.
Yes, Shell, come on up to the table. Sorry, I apologize. Yes, you are a committee member. Come up to the table.
Thank you. I wanted to ask a question in regard to the survey for medical transportation. I noticed that you don't have a survey for non-medical transportation. And since it's a community-based program and stuff, I was wondering why that is not added onto the survey.
Yeah. Yes. Hi, this is Brian McDade again from LTL. That is one of the survey questions that we do have information and we receive data on. However, I believe, if I'm not mistaken, the transportation is one of our composite measures. Okay. It's basically one of our composite measures which help us align with other states through the AHRQ as far as comparison. And also, it's one of the composite measures which are used to do the overall satisfaction of the individual. But we do review as far as the transportation needs. And one of the things is I don't believe that's a large concern, correct? But that information, yeah, I do apologize. We could do that as a follow-up if you're interested in those specific numbers. We do have the data, and we can share that as part of our follow-up from today's conversations. I just don't want to make up numbers for you, per se.
Oh,
So,
that would be great.
yes.
Can you just review again what a composite measure is versus the overall?
I will do. Yes, this is Brian, once again. With the composite measures, that's essentially there are 7 key questions which are administered by the ACBS CAP survey and then identified by CMS to help us do like a streamline to give a composite measure score or overall satisfaction for participants. So we adhere to the guidance that's given to us by CMS in regards to the administration and the data analysis of the ACBS CAP survey. So there are several questions, and those were essentially the primary 7 questions we saw at the beginning during the course of the presentation this morning. Hopefully that makes it clear for everyone.
We get kind of lonely up here at the table, Shell, so I hope you'll come join us. Paula, are there any other more committee member questions online?
Hi, Matt. This is Paula. I have no other committee member questions.
Oh,
But we have is it a committee member? We have a question in the room.
Nothing from me online from committee members.
Actually, I had raised my hand. This is the Pam Walls.
Go ahead, Pam.
This might be more of a comment than a question, but I always feel like the CAPS survey kind of misses one of the things that we hear the most from our client, which is that it's difficult to reach their service coordinators. And sometimes it's not really sure who their service coordinators are. There are various reasons I think that people have trouble reaching their service coordinators. Some of the plans require you to call kind of a main line. Others, they can call more directly, but they don't always hear that quickly. And so there's the CAPS question asks
We're kind of breaking up a little bit.
I'm sorry. I'm not sure what to do about that. The CAPS question asks if the service coordinators are helpful, but it doesn't ask, can you reach your service coordinator when you need them, or something that includes that. And I don't know if there's any available CAPS question or ability to change it a little bit that could capture it more. I think that people find their service coordinators pretty helpful once they can reach them, but we hear over and over that they just can't reach them or don't know who they are.
Yes, hi. Good morning again. This is Brian McDade from OTL. Just to respond to that, as stated just a moment ago, that is one of the composite measures in regards to the overall participant satisfaction with their service coordinator. And one of the composite measures themselves are actually several individual questions asked during the course of the survey. And that also does include the one question in regards to, are you able to contact your service coordinator as needed? So that is one of the measures which are blended into the overall composite measure regarding the service coordinator's delivery being found helpful per se. And we, looking real closely, we do have individual data for that specific question. And once again, as a follow-up, we'll be more than happy to provide that. But just to let you know, the overall numbers that we have are all actually between 92% and 97%. As far as for the state, it's an average of 95%. And then for OBRA, for that program, is at 97.3%. So essentially, across the board, we are finding that the service coordinators are being responsive in regards to the outreach from the participants, at least from the survey.
Thanks. It would be great to be able to see those individual results.
Okay. Like I said, if you just submit that as a follow-up question, and we'll be more than happy to provide that data to the group as a whole.
Thanks.
You're welcome.
I know Shauna has a question, but you had a question first. Do you still have it?
Shauna can go first. I'll come up after. Go ahead, Shauna.
I don't believe for a second that participants are not having issues with non-medical transportation. I don't believe that for a second, because as a Center for Independent Living, all I hear all day long is how people's right to go into the community is greatly negatively impacted by the transportation system as it's designed now through the MCOs. We are constantly hearing from people that they're only allowed to go into the community so many times per month. And that is a great concern, especially when you see the community participation numbers at 25%. I truly believe that people have given up on the current system as it is. And I wonder, there's a couple of things that I have been concerned about, and that is that because we're contracting transportation providers, people are often having to make transportation arrangements weeks and months in advance. And nobody can predict their life weeks and months in advance. And they're often not told. They might have made their arrangements 2-3 months ago, and they're often not told until the night before whether they can go or not go. And even when they are planning to go, very often they're not provided transportation. They just don't show up. So one of the things that I have wondered is that we're no longer using in our local communities our paratransit providers as vendors for these services. And I think that has been a mistake, because paratransit providers are required by law to provide transportation within 24 hours of the request. However, contracted providers don't have that same requirement. So I would like to see us, and I don't know who to go to regarding this, and Juliet, you may tell me to go to each MCO, and that's a very cumbersome process, so I'm hoping that you will go to each MCO and ask if we can go back to allowing consumers to use their local paratransit providers and get reimbursed for that transportation, so that those consumers can go where they want to, when they want to, and not have to get their hopes up and then have their hopes dashed. And I'm on only one center for independent living, but I hear it on a weekly basis from a multitude of people. What's the point? Every time I get excited about going out, something happens and I can't go. So these are people that are not going to answer your survey because they feel very dehumanized by this process. And so I'm just asking us to rethink this because I think it will help not only our transportation numbers, but it will help our community numbers as well. Thank you.
Thank you, Shauna. One of the beauties about being in person is we have the CHC-MCOs here today, and we'll pin that and they can speak to that when they come up for panel questions as well. A lot of great points well taken, Shauna, and certainly, we did receive a lot of recommendations through the transportation work group and those draft recommendations as well. I'm not sure if we received those transportation-specific comments via the VHC amendment comment period. Looking over at my policy folks, did we have a lot of transportation comments? All right. We will certainly note it here. I would encourage anytime there's a public comment on any of the CHC waiver or renewal changes as a SIL that represents a lot of the needs of participants, also to take that opportunity in the future. My team's certainly making a note of that. I would like to just take a moment to say that, we can certainly provide the entirety of those survey results and post them on our website or send them out via the listserv so folks can have that data at your fingertips with the composite questions that then roll up into the larger questions. Certainly there's a lot of interest in getting down into the details, and we want to encourage that transparency. So we'll certainly take that back as a follow-up and get that out via our listserv. Sound good? All right.
All right, one last question before we take our break.
Borak with United Healthcare. I noticed early in your presentation you have a slide on languages spoken, and if I interpreted that slide correctly, it looked like there was a dramatic decrease in individuals who speak Spanish in terms of their participation rate. Was there anything changed in the administration of the survey that you can attribute that to, or is it just for unknown environmental factors?
Yeah, hi, this is Brian McDade from OTL. Actually, no changes were actually applied as far as our sampling. And once again, it's a random sample, then we just call and hope individuals answer, per se, participate in the survey fully. Also, it could be just due to the completion. So it's really dependent on the individual, the participant themselves of the survey, and that they complete the survey fully to be able to be considered a complete survey by CMS guidelines. And then, of course, the language preference will be part of the response to calculations. In regards to the languages, once again, we do encourage the plans to diversify and to make sure they reach out and include a large number. But sometimes that we've seen that number fluctuate over the course of the years, and it really is just unfortunate. It's just one of those variables. It's very dependent on the participants and who actually participates in the actual survey.
Yeah. So, do you recall if you've seen it fluctuate that much? I think I saw one of the numbers was a good bit less than half of the prior year. Was that an area of concern, or just something you think is just from small sample size?
As far as, sometimes it just depends on the actual sampling, and once again, the individuals requested as far as the assistance with the language, but and their participation. Yeah. There are some individuals in which, as we have individuals who may be fluent both in Spanish as well as English, and then they participate fully in the survey as far as English and don't indicate or imply that they wish to speak Spanish or need a translator. Then of course the document is being administered in English. So, but once again, there's really no scientific answer per se.
Yeah, but nothing changes in the administration that would have contributed to it was my main question. Okay, it was just looking for opportunities for the future. Thank you.
Oh, you're welcome. And if I just want to conclude with one last statement, just in regards to the HCBS CAP survey, whether you're involved with the CHC waiver or with the OBRA waiver. We definitely encourage you to fully participate in the survey if and when you're contacted. So we definitely encourage everyone to feel that they have a voice. We want to make sure everyone is felt that they're going to be heard, because the survey, all honestly, is only as good as the participants that fully participate in the survey. So the more you are willing to encourage individuals, grassroots effort per se, we definitely stress for the participants to make sure that they're heard. So when they receive that letter, be aware of it. Also, in regards to the contact letters that go out, there is opportunity encouraged for the individuals to be able to take initiative and actually call our survey administrator themselves and to participate in the survey, because we definitely, what's the old saying, the more the merrier. So we definitely want to make sure everyone has every opportunity to be heard, because everyone's experience is especially critical and highly important to all of us that are here to serve.
On that note, we will take our break. 11:35. We'll be back. Fill up your beverages. See you then.
are going to go into the discussion portion of the CAP survey results. Before we do that, I have two quick updates. One, for the ISAC representation on HR1, over the break, I was able to get an answer, and the answer is, so if Ms. Lisa Tessler is in the room, there are two ISAC representatives on the HR1 group, same as all the other advisory committees. Those representatives are Mark Davis and Francine Hogan. All right, the second update I have is that I made an error on my presentation about the personal care homes, assisted living residence administrators dates. Those weren't static dates. Those were the dates that those free trainings were released. So they are active and currently available. So I wanted to correct the information from earlier this morning. I certainly, I guess, needed more coffee on that one. Anyways, welcoming up to the table our MCO partners from AmeriHealth Caritas, Keystone First, PA Health and Wellness, and UPMC Health Plan. And for folks who recall in the past, the LTSS Subcommittee meeting, I'm going to facilitate kind of questions from the committee members at this point, digging additionally into the data about MCO specific data you'd like to learn about and or strategies or actions they are taking in response to the CAP survey data. We just reviewed the overall aggregate, and as tradition has had it, I will randomly pick MCOs to respond unless there's a question directed to a specific CHC MCO. So opening it
Can
up.
I just ask there be one, if one of you responds and all three of you are likely the same, can you just say all of ours are likely the same? We can skip the other two.
Or ditto is acceptable. If we want to be brief. All right. So this discussion is kind of scheduled to go through until 12:15, but certainly we can make adjustments as needed. So again, this is the subcommittee working process and discussion and questions. Opening it up to subcommittee members. Anything you'd like to know from the CHC MCOs? Go ahead, Lloyd.
You might have been around to hear my earlier question about the decrease from those who rated themselves as being mentally healthy, but now being less than mentally, a little bit less, 66% to 62%. No further follow-up questions. I wondered what the results were from each of your MCOs, and how you intend to address them if there are differences noted.
All right.
Teeing it up randomly, let's go to PHW.
Can you hear me?
Yes. Just want to, introduce yourself, Marcus.
My name is Marcus Hicks. I'm here representing PHW. Sorry, I'm just pulling up the data. So for ours, and to match it up, Brian, for the box scores, did they just take the top two, or did they just take the top three, top two? So our rate would have been, for excellent and very good, it would have been 22.3%. So at this point, we're trying to work with our behavioral health team on some initiatives to work with our participants in the community. As far as specifics, I have to follow up with them to get some of the specifics that they're working on in terms of bringing that number up.
So you're saying that people from your organization that were rated through these plans, these questions, rated 23% as being their mental health being okay, as opposed to the 66 or 62 that we saw?
based on that, unless I include excellent, very good, and good, which would be the top 3 box scores, which would bring us up to 53.7%, which probably seems more accurate in terms of a comparison there.
Thank you. My heart's beating once again. But still below where the overall rating is. Is there any guess as to why that's the case? Or if not, what is your plan to find that out?
No guesses on my end. I don't want to pretend to guess, but I think our behavioral health team is working pretty diligently on it, and some of the strategies in the background. So some of that is operationalizing things on their end and strategizing to make sure that they're actually touching base with the members in the community and the people that are reporting that they're having issues with mental health. So.
All right, let's go to UPMC.
Excuse me. Oh. Yeah, I'm sorry.
Hi, this is Brian McDade from OTL again. Just to clarify, though, for the mental health, it's actually the responses that were indicated as being good or fair. So, Marcus, when you say your first number, we just want to make sure you had that opportunity.
And that brings us up to 61%.
¿Pueden llamar dentro de 2 horas? Me monté en una reunión. Gracias.
Everybody online mute themselves.
I mean, we heard about a 23% ranking. I'm not sure where that came from, but there was, I guess, excellent, good, fair, that averaged, the totaled up to 53%. Now we're hearing 61.
What we deal with through CMS. Okay, sorry. You should be able to.
Thank you. For the question for that, we have excellent health, very good health, good, fair, and poor. So according to CMS and the way we calculate it, we deal with good and fair. And that's what we show up with. As far as excellent health and very good health, we do not calculate that. And this is through CMS, and that's what they're the ones that determine what we calculate and how we calculate this.
That's the same. Sorry, but that's the same question. The health as is the mental health. I'm asking about mental health.
Yes, they're both the same. I'm sorry.
They're both the same. So both mental health and health would be good and fair, and so that's what we calculated at.
Okay. And do these calls go out to people who live in nursing homes as well?
No.
So people who are under the CHC program who are living in a nursing home don't get these calls and can't respond to their availability of mental health, which is not good.
Yeah, sorry, this is Brian again. Once again, the survey, is regarding the home community-based services, actually individuals in the community,
So there are other surveys, Lloyd. This one is focused on the HCBS, not the LTC population at this point in time for the purposes of today's discussion.
When are we going to hear about that?
We can put that on the agenda. Matt, take a note. You have an agenda topic.
Well, I didn't know I was going to ask. Thank you.
All right, not to be forgotten, we have UPMC next.
Hi, everyone. My name is Ashley Bevan. I am with UPMC. So for the percentage for fair good for us,
We cannot hear her. She needs to talk louder, please.
Sorry about that. My name is Ashley Bevan. I am from UPMC. So the percentage for UPMC mental health rating of good and fair is 59.7%. So that is those two together. And then when we look at, just because Marcus managed to bring it up as well, our excellent and very good It is 25.4%. So what we do for our participants that do state that that their mental health is not excellent or very good, our service coordinators do take a look and ask questions during each interaction that they have with the participants. And if they do notice that, hey, how are you feeling? Is anything going on? They do make referrals to our behavioral health team. Those referrals usually result in at least 3 providers that the participant can choose from. With mental health as well, the ability for our participants to, I'm trying to pull up numbers as I'm talking, and it's not the easiest thing to do, so my apologies. So those participants that do want mental health counseling and that do ask for it, we have seen an increase over last year being able to get these appointments as often as they wanted. So that is something that we're really excited to see. 67.5% of our participants that stated that they wanted mental health appointments, they were able to get that quickly. So that is a really great thing for those participants. And like I said, we do give those at least three providers. Our SCs receive training on mental health. They have the ability to attend a monthly discussion with a psychiatrist, so they can ask questions, they can learn. So they have ongoing learning when it comes to mental health. So if a participant does need assistance, our SCs are equipped to help them with it.
Thank you very much. It's very detailed, and I really appreciate that. So the appointments that folks can get, that 67, whatever that percent, 67.5% who can get the appointment in the community when they want it, those are outpatient appointments, and they include with a psychiatrist?
They are given 3 providers, so it could be just a therapist, it could be counseling, but they do get 3 options, whether it's telehealth, whether it's outpatient. They're given at least 3 options to help meet their needs, and that is the ones to get it always when they need it. There is an additional for these questions, we always give the always, but there is a small caveat for these questions where usually is also an answer. So I'm just going to pull that up just to kind of give you an idea for, so always and usually, our percentage being able to get an appointment, usually and always, is 81.9%. So a good percentage of our participants get those appointments pretty quickly.
Thank you.
All right, Numera Health Caritas Keystone First.
Hello, this is Marcy Kramer. I don't have the level of detail that the other 2 have. Brian, do you have that for me? I have the 61% for those that got treatment as soon as they needed. But while we're talking about that, I'll go ahead and talk to you a little bit about what we do here at AmeriHealth. So our behavioral health unit is on staff. So any of the participants that are seeking behavioral health providers, we notice that they do better when services can be offered in their language of origin. So we are actively working to identify providers from each of the behavioral health MCOs to make sure we can connect them with providers that speak their native language. So that's one thing. Another major effort that we have in place, we have a monthly report where we identify people that have a high patient, it's a PHQ-9 score, which is a survey patient health questionnaire that's on scores on depression. That report also includes folks that are isolated, they have unmet needs. And each month we run that report and we identify participants who may benefit from behavioral health services. So we outreach to the service coordinators and participants, and we talk with them. Sometimes it's a 3-way, and discuss the available behavioral health services, confirm if they are receiving services, and if they're not, we ask if they would like to receive services. So when a participant wants to receive those services, our service coordinators and behavioral health staff help make that happen. And then finally, and real important, our service coordinators are trained extensively. On an annual basis, they're required to complete the Zero Suicide training, motivational interviewing, demand crisis prevention and intervention and trauma-informed care.
So you're able to get back to us with the detail that the other two have?
Yep,
Okay.
I can absolutely do that.
Thank you very much.
I've got a quick question then. 25%. You guys all know what I'm talking about.
What kind of plan do we have to increase
And if you don't have plans already, you can bring it next time. But from what I understand from talking to Steve real quick, that number has never been any higher. The ability to do things in the community. 25%. That is just abysmal. I believe part of the program was to get more people in the community. Isn't that like the whole point of it? So, if possible, do you guys have any new initiatives, any new things? You don't got to spit them out right now, but, if you could get them in a little document for the next meeting, or be prepared to talk about them next meeting, that should really start climbing. Back to you, Juliet.
Yeah, just to follow up with Matt. Shell, Garrett speaking. Moving forward, how will you capture the data for the non-medical transportation? That's part A. And part B is that, will there be specific questions to address the patient concerns? Because it's not like a medical transportation, non-medical is to get back into the community. And there are a lot of concerns that needs to be addressed. So moving forward, how will you capture that data so you can rectify the situation?
All right. Up first, GPMC.
Great, I'm happy to talk about that. And I'd like to kind of bring in Matt's question as well, if I could. So we actually have a really robust plan for the community and getting our participants out. So last year during our PAC meetings, our community engagement team we went and presented and asked, what are your challenges? And the challenges we heard from our participants were non-medical transportation, getting out in the community, but it was also community accessibility, getting into specific buildings, being able, even if they're able to get into the building, they may not be able to use the restroom. So just being able to get into different buildings, different restaurants, things like that is an issue. The other issue we heard was that just their health, because the question is, are you able to go out always? And always, kind of as I segued in the previous question that we talked about, always is a very difficult line to meet. I don't always get to do what I want to do, and I'm sure everybody can say that about any topic for themselves. It's hard to do what you want to do always. But getting into the community, we have our community engagement team, and they are amazing. I can't crow about them enough. So when a participant says that they want to go into the community, that is a goal for them. They want social interaction. Their SCs create a goal on their PCSP, their Personal Centered Service Plan, and they work with them in order to help facilitate. They ask questions, they work with them. Our community engagement team has a list of resources that can be accessed by our service coordinators. They meet with them monthly. It's called our, I think it's Coffee Connections is what they call it. So the SCs come and they talk about each region and what's happening so that they can invite their participants to that. Now, if there's a participant that has a challenge in order to get out into the community, the community engagement team then works as their concierge to help them. So the SC will refer them, and then that team works as almost a focus, a one-on-one to find places and things that they can do out in the community.
Can I just interject real quick? While you decided to rope my question in, can you also rope in Shauna's question?
About the transportation?
About the problems with all that transportation and having to reserve transportation a month ahead of time.
Absolutely.
And all of that.
But if I forget, because I get on a tangent, please let me know, and I will absolutely.
Go ahead.
So just as an example, this is my favorite example. A participant mentioned to one of our community engagement team members, Lauren, he mentioned about fishing, and he has a power chair. And Lauren was able to find him a fishing spot that was accessible for his power chair. So finding areas and places that people can participate in the things that they really enjoy is really important, and they work very hard with our participants. So they work with 136 participants last year were a part of the team of that program, 49 participants so far. So it is expanding and it is growing, and they're working to get people into the community. For non-medical transportation, one thing we have told our participants that, we understand that it is an issue. We do ask, not for like months in advance, we do ask 2 to 3 days in advance to let us know that a can be scheduled. I can tell you that just UPMC does ask for 2 to 3 days, and I know that that does not mean that the ride will go perfect. We work with para transportation providers, or CTS is our transportation provider for CHC, and they do work with some of those providers. And we also offer reimbursement. So if someone happens to drive you somewhere, we do offer reimbursement for those trips. But I understand that that is not all encompassing and does not fix everything. So what we ask our participants to do is, if you do have an issue, let us know. Because sometimes we don't know until maybe it's happened a few times, and let us know each time, and we will work with those providers, those transportation providers, to help solve the issue. We will help find, maybe you have a preferred provider that you would rather use that provider instead of the other ones. For participants that go to church regularly, or they go to bingo, or they have dialysis, or they have an ongoing trip, we schedule that automatically for them, so it doesn't get missed, it doesn't get skipped. So kind of like everybody has like auto refill, a lot of people for their medications, so you don't forget. They do that for those types of trips as well. So does it fix everything? No, but that is part of what we are working on to help fix it. I think I forgot something. Did I cover it?
I think the thing that was forgotten, or maybe could utilize a little bit more coverage, is to Shell's question about how will you be tracking data for improvement in the non-medical transportation.
We do have, obviously, our grievances and where people provide feedback. So we do work with providers that we know that have issues. We work to fix those issues. Participants that have reports that they have more complex medical needs, or they have more in-depth transportation needs, we do work with the transportation providers to make sure that they can meet those needs. There are participants that are a part of that group that we focus on. So knowing that someone has the issue, we do go to work to fix it. But if we don't know that there's an issue, we can't fix it, but we're happy to work with them in order to do it. So then we find out that the issues are there. So as long as we're told, we'll work to help fix them.
I imagine you also have data on trips requested, trips completed, and trips canceled. Is that what you're getting to, Shell?
Yeah. Hold on.
I promise we'll get to the other two MCOs. I know you're eager.
Hi, Cheryl Garrett here again. No, my question is that even though you schedule your ride, you're still not assured you will have the ride. Then you call and you speak with a provider, but you don't get anywhere. You have to escalate it. Now, how are you going to capture that data so I don't have to escalate that concerns?
That is a fabulous question, and I do not have that answer at the top of my head. I know we have the data, and I can talk to our transportation team to see how they handle it. I know that they do work to escalate things, but you're talking about like real-time preventing, once you know that somebody has had these issues, preventing it from happening again. Am I following like a reoccurrence?
Okay, so this is my personal experience. I schedule my rides ahead of time, sometimes like a month in advance. And they still wouldn't have a provider for me. I have to like call, and I keep calling, no response. Dispatcher will handle it. But then again, I have to call my coordinator now and have her reach out to her supervisor, and reach out an email to whoever is in MTM at the time, to escalate the situation so I can get my ride. It's kind of frustrating. So, so my thing is that how are you going to capture that type of data I mean, are you reaching out to the clients, to the patients, to find out their concerns, and then you can compact everything and then reach out to the transportation providers?
Well, I just want to make sure I'm following. You did reach out to your service coordinator, so they were made aware of the issue. So it was escalated. So there is that tracking, so they're aware. Yes, normally that should then be escalated to where they're taking a complaint and they're reaching out to that service provider saying, hey, this is a problem. I'm not a part of those conversations. I can't give you exact detail, but I know that we do work with them. And we work to make sure that participants don't have ongoing issues. So if there are ongoing issues, we definitely want to fix them.
Okay, Michelle Garrett again. This happened last year, and that was 2025. Now it's 2026, and it's like it's happening again. So it's something that is ongoing. Even though I escalated to my coordinator, I was escalated above her, I still have to go through the same process this year, and I have to reach out to the panel now to get some type of assistance. So it's ongoing for me, and I'm sure it's ongoing for a lot of other patients.
That is absolutely frustrating. It definitely is. Can I ask, is it the same, because I'm not familiar with MTM, is that the same transportation people?
Yes, for Redding, PA. Yes.
Gotcha. I'm not familiar with them, but I agree that when something, an issue is identified, that it should be fixed. I don't have all of the answers, and I will definitely work to get at least what we do as the additional steps, as, after we've had a conversation with a transportation provider that, hey, you didn't provide the service, we contracted with you that you were supposed to provide. What are the next steps in order to facilitate getting them back to where they're supposed to be?
Great, thank you. Thanks, Michelle, great questions. AmeriHealth Caritas, Keystone First.
Hello, Marcia Kramer again. I'm Susie here. We have a lot of things going on with transportation. I'll try to answer as many as I can. So if
I'll try to answer as many of those as I can, and if not, we will follow up. I'll follow up with you personally, because I know you belong with us. So we thank you, Sean, for bringing up the question about transportation as well. So as far as reimbursement for our trips, we do offer mileage reimbursement through MTM. So participants using mileage reimbursement only, just need to call MTM before taking your trip, and that can actually be called, the call can actually be made that same day. We also offer trips through Uber and Lyft for those who may want to use that level of transportation. So people that are participants wanting to use Uber or Lyft can schedule those calls 1 day in advance, as little as 1 day in advance. For transportation, any of the concerns that we have, we encourage our participants to call their SC, file a formal complaint. We do track those complaints, and I'll talk a little bit about that in a minute after I finish here. So we appreciate all the concerns about transportation. So we use the information that you provide to address the concerns and make improvements. Our leadership team meets with MTM on a monthly basis, so we go through all the complaints and try to troubleshoot with them. There are times where we have to put providers on a corrective action plan in cases where they're not performing. So let's see what else we have for transportation. Oh, we have a monthly group, that meets bi-monthly with quality transportation, complaints and grievances from other groups across the organization, where we take a look at all the complaints, look at the trends, and track the trends, and put interventions in place if there are some concerns or issues that keep popping up as we move along. So we have that group to monitor on a monthly basis, in addition to the transportation meeting each month. And we do have direct access to call the provider, to call MTM, and raise any concerns or issues. So that's a lot of things going on with transportation. So if you want to chat with me afterwards, I'd be happy to talk to you.
And then the community integration piece and strategies for improving that.
Okay, community integration and strategies, good question. A lot of what Alex said, same thing for AmeriHealth Caritas. Our manager of a community outreach, who is here with us today, back in the back there, she and her team of folks are out in the community all the time, working with our participants, setting up activities, and working, and they are the facilitators of our PAC meetings. Our PAC meetings have been very, very successful at getting our participants in throughout all the different regions. We give them calendars of events when we are at the PAC meetings for them to attend. And as you know, our service coordinators work directly with our participants to help get them out into the community.
Great. And Pennsylvania Health and Wellness.
This is Mark Hicks from PA Health and Wellness. Again, as far as transportation, we hold bi-weekly meetings with MTM to review any services that we provided and make sure we have proper coverage for each of those services. We do like to have trips scheduled 2 days in advance, but we do not deny any trips that are scheduled outside of that time frame if it does come up. At this point, we do semi-annual trainings with our service coordinators to talk about the different modes of transportation and how to determine which mode of transportation best meets needs. We also are looking at establishing a process to proactively track MTA needs, and when we identify a medical transportation request that has been denied by MATP. And then we're just continuing to analyze our complaint data and call center escalations, and we're putting action plans in place to improve those. As far as community integration is concerned, apologies. And then as far as community integration, we continue to encourage attendance at the participant advisory committee so we can continue to get feedback and recommendations to improve. We are looking at shadowing service coordinators to identify different areas of opportunities. In addition to that, service coordinators are actually entering the plan of care into HHA exchange that's defining participants' schedule each day. We're also looking at increasing documentation around activities and agreed upon activities in terms of what the participant is looking at. Looking at implementing like a checklist for SCs to use during the participant interactions. And then we'll be looking included in that, we'll be looking at things like next steps, just so we ensure that we're identifying the appropriate next steps and it's agreed upon between the participant and the service coordinator.
Great, thank you. Subcommittee member Natalia, virtually.
Thank you so much for the opportunity. There's a lot of it's a lot of little concerns and things that I have as a participant and also as an advocate. A previous question that I wanted to ask, it was mentioned that a letter is sent to participants when the surveys are coming. Is it to all the participants? And when is that letter sent? I've been a participant for over 6 years. I've never seen one of those letters. With regards to the transportation, I would like to know, does DHS has a different policies and eligibility requirement for each county? Because every time I try getting medical transportation in my county, I don't qualify. And the reason given is because there's a car registered in my name. I was missing so much appointment to the point where my health network got involved and tried to get me transportation. And then one of the issues that we have in this area is the fact that if I want to go to my religious service at 7:30 at night, I can't depend on the non-medical public transportation because they stop at a certain hours. And my question is, are the non-medical transportation or the medical transportation, there's a lot of obstacles as being mentioned with the previous panelists that's in person. And that's just a little tiny list of all the obstacles that we have faced. When I look at my service plan, nothing is ever talked about transportation. Nothing is discussed about transportation because I guess some of the service coordinators, even though they might be excellent on their job, they assume that because you have a vehicle, there's no need to discuss the transportation, I guess, or to offer these things that are available. This is the first time that I hear that AmeriHealth offers Uber and Lyft transportation services. I don't know if it's for medical or non-medical transportation, but however, it sounds like service coordinators are responsible for so many things to educate a participant. And it's very interesting when I come to these meetings and I hear all of these things that are in place and service coordinators being trained, but the information is not getting out to us, the participants who are in dire needs for transportation in a lot of places. And my other question that I was going to state, hold on, I missed my question. Dual eligible participants have even a more difficult situation to get transportation, and I don't understand why. I really don't understand why there's a issue with us. And mileage reimbursement, when you do mileage reimbursement, I know that all these programs are cost containment, and mileage reimbursement will probably be more less costly than using an Uber or a Lyft ride. But when you do your mileage reimbursement, when gas is almost $5 right now, that doesn't even make a dent for the people who drive you to these places. So
Natalia, that was a bunch of questions. So in the interest of time, I'm going to just step in for a moment, apologies, to let the MCOs start answering some of them, because even I am going to have a little bit of difficulty in remembering all of them to make sure they stay on track. Is that okay?
That's fine. Thank you.
Okay. All right. AmeriHealth Caritas, you are up.
Okay, hello, Marcy Kramer. So a couple different things, touching on the transportation. That ties in really well with your PCP, including all things important to you. So our service coordinators are being trained to make sure that they ask that question to the participants whenever they make contact with the participants. So because we want to make sure that the participants have everything in their service plan that they want. So our service coordinators are now required to have that 90-day telephonic outreach and then at least a 180-day in-person visit. So during those two touch points, we'll be asking those questions, and certainly transportation should be a part of that. So if it isn't a part of your service plan and you want it to be a part of your service plan, don't hesitate to contact your service coordinator. Sorry. Okay. So with that said, wow, that for transportation, that's a huge part of your PCP, including everything important to you. And another question, what other question can I answer for you?
So any considerations with regards to mileage reimbursement changes given the high cost of gas right now?
Oh, that's something I'd have to get back to you on. That's not my area.
We'll take that back as
Yes.
feedback. All right, Pennsylvania Health and Wellness.
This is Marcus Hicks, representing PA Health and Wellness. Ditto. Getting back to you on the mileage issue. At this point, as far as the survey, it is a random sample. That would probably be why you didn't receive it. You were probably not in that random sample selection. As far as the daily schedules right now, we address our service coordination involvement by having them ask about transportation, and we educate our providers on the importance of incorporating any participant preferences when they're creating the daily schedule of care. Again, I'll refer back to making sure that participant advisory committees, making sure that there's as much involvement as possible so we can get feedback there on any issues inclusive of transportation. And if you're having any issues, always just make sure to let your service coordinator know and loop them in as well so they can contact the appropriate parties and the appropriate departments within the health plan so we can get it to the right people and we can resolve the issue.
Thank you, Marcus. Ashley from UPMC.
Not sure which mic's going to work best. Again, Ashley from UPMC. So I'm going to make sure I cover these. So with transportation being offered, that is something our SCs do have a conversation with, similar to the other MCOs during that PCSP creation, the person-centered service plan. So we do ask about it. From what I understand, there isn't an exclusion specific for participants that have a car or a vehicle. That is not something that we would deny because of that. So I just wanted to state that that's not something that we have. I'm trying to remember the other questions. I'm so sorry.
How your survey responses go out?
Oh, yeah. Same as the other MCOs. It's random. And the only people who receive the letter are the ones that are in the sample.
Great.
The same vendor handles.
Thank you. I do see Pam that another committee member has her hand raised. Pam, your question is.
Let me just ask, Ashley, can you just follow up with the Lyft and Uber? When does that come into play? I've heard Lyft and Uber talked about a lot here.
We also offer Lyft. It's for participants that are able to utilize the service to get into those vehicles. It is available during normal business hours. It is also something that they can use after business hours and on weekends. So if you have a later appointment or doing something on the weekend, that is something that we help them sign up with.
Help sign up and you pay the entire cost.
Mm-hmm.
Did everyone at home hear that?
I want clarification on that. How do you make sure that the Uber and Lyft providers or drivers that are working with you have wheelchair accessible vehicle for us that have power wheelchairs or wheelchair bound?
So it's kind of how I said, if you're able to utilize those vehicles. So it is unfortunately not something that is universal like some of the other transportation options, but it also, if a participant who is able to use the Lyft vehicle can use the Lyft vehicle instead of using one of the other transport vehicles, that frees up that other transport vehicle for a participant that would use a power chair or a wheelchair. So it expands the options to free up other slots.
So I'm feeling the reaction from the room. I would recommend that discussions with Uber and Lyft about full accessibility will certainly be very important to keep continuing to move the needle towards full universal access. All right, Pam.
Hi, I'd like to go back to, I think it was Marcy Creamer from AmeriHealth's response about community integration. She said that service coordinators work with our participants to get them out in the community. Could you elaborate on that and tell us more about what specifically what the service coordinators do?
I believe that was for me from UPMC. Ashley, am I correct?
No, it was from AmeriHealth.
Oh, sorry, I heard her.
Yeah, I'm reading the question on the screen.
Oh.
Sorry.
Hi, this is Marcy. I'm reading the question on the screen here. So elaborate on about what specifically the service coordinators do for community integration.
Yeah, well, you said that the service coordinators work with participants. Could you elaborate on just specifically what do they do?
Yeah, well, the service coordinators, obviously, they're out in the community meeting the participants face-to-face to do their assessments and their care plans. So as part of the person-centered service plan, that is part of the plan itself. You know, we're looking to get people out into the community, and what does that mean? It might mean different things to different people, maybe for religious activities or just to meet family and friends in the community. So part of our...
Can I just interrupt you? Are you saying that the service coordinator meeting the individual at their house is meeting someone in the community?
No.
All right,
no,
I just want to make sure that you weren't
no.
saying that.
Meeting someone in the community is more like family, friends, and activities. No, sorry. Yep. So the service coordinator's role is to help develop that plan to help you make those plans to get out into the community, whatever those plans may be. And it may look different for each participant, as you know. So they do their best to line things up so that the participant is able to get out into the community. So it should be recorded as part of your PCSP. Make sure we're getting you everything that you want to do out in the community. And if you need any more information, I'll have to go back to the service coordination crew and get you some more detailed information.
If I could just follow up, my question about the 25%, I think all three of you gave me abysmal answers. It doesn't sound like any of you have any plan to increase that 25% at all. Just a comment.
All right.
So, want to move to the, sorry.
Well, actually, just if I could just follow up on the response to my question, that would be great to get additional information. It has been our sense from what we hear from our clients that service coordinators have heavy caseloads and have a number of tasks to get through. And I don't get the sense that there's a lot of conversation happening around community integration. And I think it's even worse affected. Some of the time and task tools, Keystones is the one I'm most familiar with, have nothing in them for going out into the community. And because people often will need their aid to go with them into the community, that's a real problem, that's not part of the time and task tool. And so it ends up effectively not being included in the service plan for people who need their aid to go out in the community. But I would love to get more information about that, because I don't think there's a lot of thoughtful conversation going around on asking people what they would like to go out into the community to do and how that can be facilitated.
Thank you, Pam. I appreciate that. Just to kind of round out the panel, I think it's clear from the LTSS Subcommittee meeting members that around this time next year, when we revisit CAPS, they would very much like to both hear about strategies to improve community integration and to see those numbers increase meaningfully. Would that be fair, Matt?
Absolutely.
Okay. So we're going to close out this panel. We're going to say thank you to the Office of Long-Term Living team, Brian and Steve, and our CHC MCO partners, Ashley, Marcus, and Marcy. Sorry, I knew that, Marcy. So we're going to excuse them from the table because, certainly we understand there may be additional comments and questions related to the CAPS. Our team will document those comments and questions and send them out for follow-up. Because the panel is kind of scheduled for this time, we're excusing them. We're going to send them out after the meeting as those follow-ups. And okay to move into public comments?
Yep, thank you all. We'll start off with public comment in the room. Anybody? Shona, go ahead. Are there any committee members online or in the room that have questions?
Ginny Rogers has her hand up.
Go ahead, Ginny.
Hey guys, I've been really interested in this transportation conversation because I have also heard significant issues with access to transportation with regard to especially time of days and limits for transportation. And I had in my mind, I think Matt, you raised it earlier about or somebody did, maybe Shauna, about the requirements of the ADA and the timing and so much of that. And I think assumed that was essentially happening just across the board, even with the subcontracted drivers. So one, I want to say yes, encourage MCOs to continue with Uber and Lyft, but we have to find a way to ensure that people who cannot use Uber and Lyft because of accessibility have the same opportunity to travel on a Saturday or an evening, even if it means extending schedules of paratransit vehicles or whatever needs to happen to make it more equal. So I would like to say this is something that we need to continue to work on, and hopefully we'll continue to have this on the agenda for discussion. Thank you.
Thank you, Jenny. Any other committee members online, or go ahead, Lloyd.
Thank you, Lloyd Wertzer. From last week's MAC, we learned that pretty much the only resource that DHS will accept for receiving commentary about how to deal with horrible resolution, HR 1, is through the MAC. And of course, there are these subcommittees of the MAC. And I'm wondering if we want to think about scheduling a brief time at future meetings where that kind of input can be called for and then shared with the folks who represent the LTSS subcommittee on that stakeholder group, which I think are Pam and,
Pam and
Rebecca McTaggart and Jim Waltz are the LTSS committee members.
I just think if that's the only way we can have some input into the DHS's plans to deal with possible service reductions, that might not be a bad way to do it.
So it's not the only way. Folks, anyone can also submit a comment or feedback to the resource account that goes directly to the HR1 team. But with regards to the LTSS subcommittee workings, certainly at every LTSS subcommittee meeting, there's going to be HR1 as a standing topic. Catherine Stetler is working to align the HR1 meetings with our meetings. So between the last meeting and this one, there wasn't any activity for HR1 for Rebecca or Pam to really speak to, except for the RA account, so I did that. But certainly the subcommittee topics, the chairs, if you want more time to focus on a specific aspect of HR1, I would just recommend that you raise that up to Pam and Matt, and they can work with our team to make sure there's more time on this agenda to do that here. I know the other subcommittees are moving more towards a kind of working committee with more working time on different things in agendas in their agenda meeting. We're a little ahead of the game, which I love. I love that. So, you'll see more opportunities in each of all of those. I would anticipate, they're not my meetings, they're not my committees, that they would also have more working time, and also welcoming folks to use our public comment period time to come in and inform all of us committee members about anything related to HR1 that they're thinking about as well. So all of those points are well taken.
Good news. Thank you.
Thank you, Lloyd. There are two committee members online, but go ahead, Shauna, you're already here.
I just need to go on record as saying a couple things. One, I hope that we spend ample time throughout this year working together to ensure that the MCOs increase that 25%. I don't want to wait till next year and get the same percentage and have the same reasons behind it. One. Two, one part of my comment wasn't addressed, at least while I was in the room, and I just want to ask, if we are paying for Uber and Lyft for folks that can access it, I want to point out that the only city I've been able to access an accessible Uber/Lyft is New York City. And so if we are paying for that for some participants, why can't we, as an accommodation, while we're working toward making Lyft and Uber more accessible, why can't we allow participants to have a budget again where they can use their local paratransit system? Because in Erie County, as an example, it's $3.50 one way to go where you want to go, and they have to pick you up within 24 hours of your request. And so, to me, $7 is a whole lot less expensive than Uber and Lyft anyway. And we're not allowing people to put in their budget that they can get a paratransit ride because they have to use MTM or CTS. And we've heard here that that's not working very well. And I have story after story after story that can back that up. And lastly, I guess I'm disheartened because these services are meant to empower people with disabilities to engage in their community. And what I see is the actual effect is very disempowering, because I have consumers tell me, like I said, in the hallway, that their service coordinator put in their budget that they're only allowed to come to Voices on Thursdays, and they have no other social interaction in their community. And I have other consumers saying, you know, I've tried and tried and tried and tried to get rides to go to family birthday parties, to go to family dinners, et cetera, et cetera, et cetera. And I think I'm going, I get all dressed, and then they never show up, and I call, and they say, we couldn't find a provider. So what's happening is people are giving up. They're feeling disempowered. And it really doesn't, it's disheartening to know that what I hear here in this room and what I see in my communities is so opposite one another. We need to do something. And I think in the short run, one very simple thing would be to allow people to use their local paratransit system and reimburse them. If we're reimbursing mileage, why can't we reimburse paratransit?
Thank you again for that comment and suggestion. You want to go to?
Thank you, Shauna. Lynn Widener.
Oh, I think she put her hand down.
Is Natalia, do you have your hand up still?
Hello?
Yes. Okay. Helen, go ahead.
Hello?
Go ahead, Lynn.
Sorry, I didn't know if you could hear me. My comment and question, I was just wondering about a follow-up to the wage increases, and I wanted to know if we had like any progress report on like how many participants have actually returned the wage increase forms, and if we knew like a percentage of the universe of participants that are actually utilizing that.
Hi, Lynn, this is Juliet. I do not have any progress reports with regards to who answered the forms. That's not something we routinely look at. However, we can certainly put the question out to the CHC-MCOs within their system and send their response out after the meeting.
Thank you.
Natalia?
I have a couple of comments, and I wanted to get clearance with regards to the survey that Mr. Bryan mentioned, that letters go to participant. I just want clarification that those letters only go to those participants that have randomly been picked, not to all the participants.
Natalia, the letters for the CAP survey are only sent out to participants that are part of the randomized sampling process. That is the standard process for the CAPS member experience survey. So it does not go out to every participant, it goes out to the randomized sample.
Sounds good. Thank you for the clarification. And then moving to the transportation and the community integration, I am going to be agreeing with Shauna. In paper and in these meetings, these programs sound amazing, offering services to us, the participant. But out here in the ground, in the real life, it is a totally different story. So I would love to see or to hear what plan or what actions are the MCOs going to be taking or put it into place to assist the service coordinator. Because in every meeting that I have been so far, I hear a lot that is being expected for service coordinators to do. With regards to AmeriHealth saying that the service coordinators, what was the word? It says service coordinator are in the community participating in the participant center service plan, talking to participants to develop their community integration. I have never, in the 6 years that I've been receiving these services, ever gotten an answer or gotten the assistance to do community integration. Number one, I'm in a tricky situation where I'm to the left is one county, to the right is another county. If I get medical transportation, they won't cross over to the other county to take me to my PCP's appointments. If I'm in my right, they won't go to Allentown to take me to my specialist. If I were to qualify, because till this day, I have never been able to get medical assistance. Never, ever had I ever been offered, you know. And then when you do ask and you tell them about this, you don't really get an answer. So I would like to know what is the MCOs planning to do to assist the service coordinator? I mean, they already have a crazy overload caseload. How is it that they're going to be doing all of these? Because let me tell you, as amazing as my present service coordinator is, we have never had a conversation of community integration. We have never had a conversation of transportation and how there's this services out there for me. And I heard that there's a lot of training being done with the service coordinators when it comes to the mental health and the behavioral health.
Natalia, there is other questions. Can you try and narrow it down?
So what is my most important question right now is, what are the MCOs planning to do to increase the timeline or the time constraint for service coordinator to accomplish all of these tasks that is expected of them?
Sure. Natalia, thank you for the comments and the explanation and the question about the service coordination. One of the things that I would note is the CHC MCOs are currently working on reducing service coordination caseloads down to 1 to 50. That's a significant change that has been implemented in the CHC agreement. Still early stages, still working towards that goal, still monitoring it with the CHC MCOs. That should hopefully reduce the SC time with regards to other kind of administration work so that they can spend more time with participants doing person-centered planning. More specifically to your question and to your situation, it prompts me to remind every participant in this program that they can contact and should be able to contact their service coordinator at any point in time to have a person-centered service plan meeting at their request. So it's not just once a quarter. If you want to meet with your service coordinator once a month, it is the right of the participant to make that ask and have that need met. So if there's a participant that goes, you know what, I just learned today about transportation. I just learned today that I can have these more in-depth conversations about community integration, things that I want to do, and I need my SC to partner to make sure it's in the plan to the extent that I feel satisfied and I am eligible for those services. A participant can call up their MCO and put in their person-centered service plan, I want to meet with my SC once a month. I want to meet with my SC every Friday. It is the participant's right to engage with their SC as often as they believe they need to in order to get a person-centered plan that meets their needs and update it accordingly. I hope that's helpful. I may sound a little amped up on that, but I hear it often that, participants think that there's this expectation that they can only meet with their SCs when their SCs want to. And I just want to be absolutely clear, that is not the case. The participant drives that. And if folks have difficulty getting more frequent visits with their SCs to be able to help them explore their goals and meet their goals, I definitely want to hear about it.
Thank you so much.
If I can just say,
thank you.
I'm on Act 150, but it's about the same, I think, everywhere.
It is the same.
I text my service coordinator all the time. She texts me back. I really don't need to see her. But anyway, Michelle, you had a question.
Yes,
Michelle Garrett. I don't think I have a question, just a statement I would like to say. It would be great to remove random from the service letter so we can get a broader data collected. I think that's the whole issue here is that we are not collecting the correct data to resolve the issue, and we keep going around in circles trying to find a solution without the correct data. So.
No, I don't disagree with that statement. The randomized sampling to get the statistical responses, there's a significant cost with surveying. So, that's why we do that sort of randomized sample of the population. It helps us to kind of have a certain amount of cost to the surveying that's reasonable to do a systems level test. If we were to survey everyone every year, it would take a lot of the dollars for direct services and throw them into administrative stuff. So it's really that balance between what can give us some meaningful insights, right, broadly speaking across the system, versus like if we survey everyone and still get the same 25% result, right, 25% is telling us this is an area that we need to focus on. I'm not sure surveying everyone in the program would kind of change that sort of red flag that this is what needs to be focused on. But your point is well taken. I wish we had the resources to survey everyone.
Well, can we encourage members to actually do documentation on complaints? So those complaints can be recorded and used as part of the data collection for the survey?
Not for the survey, but we absolutely do evaluate, collect data on reports and complaints and grievances. And to, Shauna's comments, if a SIL is working with a participant, I would encourage them with these issues to kind of help them take that step to do that sort of complaint, to call the helpline at OLTL, to also share it in the moment, because we do look at that data. We've reported that data out to this subcommittee about the complaints, grievance issues, and topic areas. Happy to do it at any point in time that you'd like to look at it. So did want to raise it up. All very good points.
I don't think you're Carol Marfisi.
I am not. Does anyone else have questions?
Oh, sorry. Does anyone else have questions? Sorry, I didn't know if we were the public.
I wasn't sure if you were a panel member. No. Pam, are there any questions online?
Hi, am I in charge of online questions, or is that Paula who does that?
Hi, Matt. This is Paula. We do have questions and comments online. I do have folks that have had their hands raised for a while. So where do you want to start?
Any committee members?
Very well.
No committee members from my end.
Well, then why don't you give us a couple, and then we'll go in the room here.
Great.
Okay. From the questions, I had a comment from Anthony House and a question. So can the presenter, this goes back to the CAP surveys with Brian. Can the presenter share a bit about the implications of the data and the rationale for the way race was indicated and recorded?
Paula, I'm trying to see it because I had a little difficulty hearing you.
Was Anthony House. Can the presenter share a bit about the implications of the data and the rationale for the way race was indicated and recorded?
I think the presenters, I think Brian addressed that when he was commenting about how the surveys were presented, like get randomized sampled, and when the individuals were called and offered language, line assistance and things of that nature, that data was part of that survey piece. We can certainly follow up to see if Brian would like to add any more to that. As a follow-up, I know Mr. House did indicate he had to leave the meeting, so we can follow up after the meeting.
The next question or comment is from Brenda Dare, and I can unmute her. Brenda, if you can unmute and ask your question.
Thank you, everyone. It's really a comment. I do have a couple of questions that are in the box and can be forwarded for follow-up, but I want to make an urgent comment about the transportation situation. In allowing MCOs to partner with Uber and Lyft, but not requiring them to partner with local paratransit services, our state and this department are contributing to the discrimination that is ongoing against people who have mobility needs and cannot access these services. And as a participant, I would absolutely demand that enforced contracts be had with all paratransit services. It's the only way to equalize, and it doesn't even really equalize, but it's the most equal solution that's possible now. Yes, MCOs should work with Uber and Lyft to make them more accessible, but we know that's a decades-long process in the making. Immediately, MCOs should be required to engage in contracts with all local paratransit systems. Thank you.
Paula, any of the other comments that are in the chat, can we just forward on? Are there any active questions in the interest of time?
Question from, this is Paula, question from Paul Ramar. Has there been any discussion at the county or state level regarding the feasibility of expanding paratransit service models beyond curb to curb, particularly for CHC eligible populations, in a way that would allow for cost sharing or system alignment, thereby reducing reliance on waiver funded services for transportation related assistance?
Paul, thank you for the question. So paratransit is a county-by-county service that is typically run by the counties for that. So what I can say is, OLTL does not have jurisdiction over the counties and how they operate, or even if they're willing to contract with CHC MCOs. That is a county-by-county decision. What I can do and would be happy to do based on this and other comments that we've received around paratransit and county services is the Department of Human Services has a liaison to all the county commissioners at Brenda Peniak, and I would be very happy to raise these issues and questions and feedback up to her with regards to the county paratransit, the cross-county travel, and other needs from the LTSS Subcommittee and members at large that have commented today, and provide that feedback to her to engage with the county commissioners on behalf of DHS, so she can also provide that feedback directly to those commissioners. So certainly happy to do that.
Thank you. Go ahead with your question.
Sorry, I'll be quick. So this is for the MCOs. Maybe we can get an answer.
State your name.
Oh, sure. Sorry. I'm CJ. I'm a provider. I'm from Angels on Call and the Honor Health Network. My question is for the MCOs because I know with OLTL and with ODP, participants and the caregivers can clock in and out in the community without having to have a specific address in their profile in HHA Exchange. Whereas I know some of the payers have taken back funds for not clocking in at an approved address. And so that's been something that's come up in just some of our public policy meetings and things like that at the association. So I was just wondering, has there been any thoughts from the payers in adopting the OLTL and the ODP practice of allowing community visits as a I guess, compliant visit without a timesheet?
Thank you, CJ, for that question. We'll send it to each of the payers and request a follow-up answer to your question to be sent out.
Thank you.
Any other questions online, Paula?
Hi, this is Paula. I have a question from Thadwa Robinson. Participants are being told transportation needs to be on their care plan, so they can't contact MTM directly unless service coordinators authorize transportation. Is that information correct?
We'll get that question sent out as well, specific to MTM, so that we recognize that.
Any others?
This is Paula. I have a question from Natalia Gomez. Can all three MCOs consider reimbursement of paratransit costs?
So, Paul, I think Natalia asked that of the 3 CHC MCOs, but we can also request them to have a more formalized response as part of the follow-up.
I have Bill Herzog, who has a couple questions. I'm going to unmute you, Bill. Are you able to unmute, Bill?
Can you hear me? I am now unmuted. Can you hear me?
You're very low.
Okay. Maybe, let me just see. Maybe I can get closer to my microphone and I'll try to speak up. I just wanted to make a comment about the MCOs and how they are getting all these questions from the committee and the community, and then they are responding and via the listserv, which really nobody has any idea where that is at. All of these MCO questions are now seem like they're going under, so you can take them to the MCOs and that they can respond. There's never no answers to these questions. So I think the MCOs need to be more held accountable for some of these questions and concerns that people are raising. And when is OLTL going to put their foot down with the MCOs to quit trying to deny, and delay our services? When is this going to stop? Thank you.
So first, thank you for your comment, Mr. Herzog. We will also capture the comments in chat as well that were there. With regards to the listserv for the LTSS listserv, I'm going to ask a member of my team to email you the steps on how you can register for the listserv. Information for accessing all of DHS's listservs are online at the DHS webpage, and certainly we can make sure we get you connected. If need be, and if the committee would like, we're always welcome to walk through and take time as a committee member to walk folks through how to sign up for our listservs, but we certainly do encourage folks to get connected to the listserv because that's where a lot of our information is disseminated. So, Bill, happy to have a member of my team connect with you.
Bill, if I could, this is Matt Seeley. It sounds like you made a couple generalizations there. If you have specifics or things that you really want to comment on, I would please ask you to submit them to that account or email either Pam and I directly so that we can share some of those concerns on.
Well, Matt, I hear you, but we've already gone over a lot of this. The questions have been submitted already in regards to reductions in services, in regards to the transportation issues. there are many issues, Matt, and it just seems like nobody ever wants to deal with them. They just want to, push it under the rug, put it on a listserv, and then nobody ever even gets any real answers. Why
Well, I can tell you that that is not true, because I see this document that Juliet gives me every month that says Randy contacted this person and solved this person's problem. I don't know what the problem is, but I see that document every month. So Randy's on the phone with a lot of people doing nothing.
Obviously,
Apparently.
there has been this problem now since the MCOs have been in existence. So I'm just curious, what is going to happen to make sure that these MCOs are providing the services to us participants in a timely manner? That's all.
The one thing I can suggest is that you continue to be on the phone monthly at this meeting and hold their feet to the fire. That's my suggestion to you right now, Bill. But with that, we are running out of time, and I will entertain a motion to adjourn.
May I just make one?
Sure, Juliet.
So, Bill, certainly appreciate it, and transportation is a hot issue. It's one we continually work towards. I do have one caveat, though, and correction, that transportation has been an issue way before community health choices and the managed care organizations. It is, if I had a magic wand and could fix it through the Office of Long-Term Living, I certainly would. But it is going to be an issue that requires a lot of cross-agency support through our friends at PennDOT, Department of Transportation, and also a lot of will from the representatives to help support what's needed with transportation infrastructure. But certainly OLTL will always make our efforts and continue our efforts to try and make progress where we can and where we have authority to do so.
Gravy. Anybody want to adjourn? That takes like a committee member.
I would like to adjourn. Yes.
Michelle says yes. We are adjourned. See you all next month.
Thank you.
Thank you.
Yeah, I hope you didn't have your day.